Hello, this is Professor Denham, and today I'm going to discuss Chapter 6. Chapter 6 title is Nursing Care of Mother and Infant During Labor and Birth. Okay, so in this chapter, your key terms were very important: absent variability, accelerations, acrocyanosis, adjustment, amnio infusion, amniotomy. So, and that is on page 123 in your textbook. So all these key terms we're going to be discussing now as we progress through chapter 6. Alrighty, I'm going to go ahead and share my screen. And I'm going to bring up my PowerPoints so that we can discuss this together. Okay. Alrighty. Okay, so here we go. Okay, so again, we got the nursing care of mother and infant during labor and birth. We're going to be discussing the labor and birth process. Okay, and now she's been pregnant, all right, and so now it's time for her to go through labor, which would give birth to the baby, and then we're going to discuss postpartum and what happens to mom too. Okay. All right, so we have some cultural influences on birth practices. The role of the woman in labor and delivery. Her cultural preferences require a lot of flexibility. And the role of the father and the partner in labor and delivery, it may be driven by cultural practices. They may not be, the father may not be wanting to participate per se in the labor, okay? And that could be because in his culture, the men don't do that, all right? So again, as nurses, we are culturally diverse. We are culturally sensitive. And so therefore, we don't make any judgment. And, we just want to make sure that the woman in labor has support. So again, we're going to be sensitive. Now, if maybe you get a question like such as this: which of the following nursing actions demonstrates cultural insensitivity in the care of the laboring woman? So that is a little different. So this is culture. Which one which demonstrate cultural insensitivity? So the only one I can think of looking at these would be for B as in boy, as insist that the mother remove her head covering. Again, some cultures require that the woman, they cover their head when they're out in public. And you have to be sensitive and allow that to happen, for her to keep that on her head. That's all part of her culture. Okay. Now, in your book, it goes over some settings for childbirth. Remember, childbirth is a normal physiological process that involves the health of the mother and the fetus, who will become part of our next generation. That's how you have to look at it, right? So it's a natural process. That's how we all came to being. Now, our settings for our childbirth, they do vary, okay? So we have a couple. We have hospital settings, we have freestanding birth centers, and we have home. They all have their advantages and disadvantages. The hospital has lots of advantages because you're in a beautiful setting such as this right here, as you can see. And you have a couch over here for mom and for the partner or her mom, whoever's in the room with her. And you got a nice rocker. And over here you have a flat screen TV. And the couch folds out to a bed. So if she's in labor a long time and they get tired, they can rest. So it's just like a home setting. Okay. And a lot of times this wall here, this the suction and oxygen, is covered by a wall. And a lot of times we keep that covered until we need it. And so again, you don't see that. And then here is the crib for the baby, and have a nice armoire, you know, and nice cabinetry. So it looks just like a birth center, except in the hospital here, in case that the baby took a turn and all of a sudden had recurrent late decelerations. And, you know, you, and, and,
Would you do a peduncle block?
oh, excuse me. Okay.
And
Oh, hello. Okay.
I just had a question. Are you able to post this when you're done? Because it crosses over into our class time.
Oh, yeah, that's fine. Well, let me just stop recording. Okay, so now I'm going to resume and go back to where I was. And we're talking about the different childbirth settings. Okay. All right, so again, the hospital setting, you know, you can have a C-section really quick, you know, so therefore the hospital setting is the best, you know, but if you want to, you know, have an alternative, there are alternatives, the birth center, except a disadvantage there if she, you know, if she needs to have a C-section, or she had all of a sudden she spikes a fever, she's going to have to be transferred to a hospital setting. Now that's something to think about. And then the home setting would be kind of dangerous for a prima gravida, a first time mom, because she doesn't have what we call a proven pelvis. And so, you know, if these home births are really good for women who are multiparas, okay, because they have a proven pelvis, they delivered other babies vaginally, and so that's a nice thing too. So they all have their pluses and their minuses. Okay, let's go on. So let's get into the components of the birth process, and I call it the 4 Ps. Okay, so let's talk about the power. The power is your uterine contractions. Okay, the contractions, they will dilate and face the cervix. That's their job. Okay, the contractions during the second stage of labor will help push the baby out. Then you have the passage, which is the patient's pelvis. Okay, and we talked about that in another class by the different pelvises. There's 4 different pelvises, and the best one for a vaginal delivery is the gynecoid. And then you have the passenger, who's the fetus. And you know, we hopefully he's not getting too big. Once you get to term and then you get to late term, the baby starts to get put on weight and gets big, and then you run into a problem with delivery. And then you have the psychic, which is the emotional state of mom. Other factors that can influence the progression of labor is she prepared for her labor? Okay, you know, we offer prenatal classes, but not everybody takes those prenatal classes. Does she know how to do her controlled breathing during the labor? Okay, those are really good preparation practices, you know, and we strive to make them available to women so that they can be prepared and to, you know, breathe in and out, learn how to breathe in and out. And it's best to do it beforehand, to learn all that beforehand before going into what? Labor. All right. So we talked about contractions as the power, and we have a type of contractions, and they're called Braxton Hicks contractions. Now, Braxton Hicks contractions are irregular contractions that begin in early pregnancy, and they intensify as a woman gets closer to full term. I would write this term down, Braxton Hicks, because that's always a good question. All right, you might see this again. So Braxton Hicks contractions are irregular, and what happens is that these contractions, you know, they don't really dilate and efface the cervix. So they can be very annoying because they're not doing anything. But it's good that the body's starting to what we call rev up and for the true labor. Okay. So let's talk about a uterine contraction because this is the power. All right. This is what has to go on. And what they do is that they efface and dilate the cervix. That's the purpose of uterine contractions. They're going to make that cervix thin out, and you go from 0 to 100% effacement, thinning out, and then dilation, she goes from 0 to 10 centimeters, and at 10 centimeters, she's completely dilated. So that's their purpose. So write down uterine contractions, their purpose, effacement, and dilation of the cervix. Now, you have contractions, we have 3 phases of a contraction. So you have an increment, you have a peak and decrement, okay? So let me show you here, and I'll talk about frequency and duration while I do that. So let me go to the whiteboard here. And let me go ahead. Oh, hi, Megan. And let me go ahead and go to my whiteboard and show you a contraction, all right? Hey, so I'm going to go here and I'm going to draw my contraction. Okay, here we go. Here we go. Okay, all right. So the increment is going up. See, don't these look like little waves too? I mean, I heard that description this morning and I thought that was pretty nice. Okay, so going up the contraction, this is increment. So think of increase, it's going up, okay? And then when we get to the top of the contraction, that's called a peak, okay? That's where the strongest portion of this contraction is, right up here. And then as it starts to go down, it lets up, all right? And so that's called decrement, decrease. So remember, like increase, increment going up, gets to the top of the contraction, the peak of the contraction. And another term you may hear or read is called the acme of the contraction. That's the top, that's where the greatest intensity is. And then you have decrement or decrease right here, going down, all right? So that's the phases of a contraction. Now, when we talk about frequency, and we always ask our patients, how often are your contractions coming, okay? That we're looking for frequency. So we're going to determine frequency. We're going to count from the beginning of one contraction, see here, and we're going to count to the beginning of the next contraction. That's frequency. How often? Usually we're talking about early labor, maybe 5 to 7 minutes apart, in the early phase of the contractions of labor. So that is frequency, okay? How often are the contractions going? Now, I know this is an important term, and you'll probably see it again, so I will write that down. And then another good term that you need to know is duration. All right, so that means duration. How long is this one contraction lasting? Because a good duration pattern goes from 60 to 90 seconds. I don't want a contraction greater than 90 seconds. No, no, no. From 60 to 90 seconds in duration. So I count, now listen up, from the beginning of this contraction to the end of that same contraction. This interval here is duration, okay? So we've gone over the phases of contraction, the 3 phases, increment, then you got the peak or the acme, and then you got decrement, okay? And the reason why we go over this is because as nurses working in the labor room and an LPN helping out in the labor room, this is why we would ask you to help the patient breathe during a contraction. And so when you see this monitor, you see she's starting to go up, that means she's starting to have a contraction. You want to help her breathe. Take some good slow breaths. Come on, breathe in and out. Breathe in and out. Control breathing. Then as she gets to the top of the contraction, that's where the greatest portion of the pressure is, then she might go into a little faster pace because it's painful. So she might do this. I'll demonstrate it for you. It's like, it's faster breathing during that time. But as soon as that contraction lets up, get her back to that slow chest breathing, okay? Then you go back into slow chest breathing during the decrepitment. And then she has a little rest. This is called the rest interval between the contractions. Let her rest, okay? Because then her next contraction comes and it starts all over again, okay? And the breathing starts all over again as she goes up, the increment, gets to the top, the acme or the peak, and then as soon as you can, get her to slow down her breathing during the decrepitment. Now that is a contraction here. So let me close this up and we'll share back here and let's go here. Okay, so we talked about what the cervix, what the contractions do, okay? And you know, there's a lot of nerve endings down in the area of the cervix, and that's why it really does cause discomfort to our patients. So that's the role of the contraction. That's the phases of contraction. We talked about frequency and we talked about duration. The intensity on external monitoring is either mild, moderate, or firm. And I think if you were with me yesterday, I said touch your nose, and that's a mild contraction. And if you touch your chin, that's a moderate contraction. And if you touch your forehead, that's a firm contraction. And that's how we actually teach new nurses how to determine intensity by just putting your two fingers on the fundus of her uterus, and you can feel the uterus come up, and you can feel how intense that contraction is, okay? And then again, maternal pushing, that the contractions again will help her push that baby out, okay? So that's the work, the contractions. They have a lot of work. Now, as LPN working in the labor room, when you're looking at, you know, your patient and you're looking at these contractions, we don't want them too quick. We don't want them like every minute, minute and a half. We want them to be at least 2 to 3 minutes apart, okay? Because the baby during the contraction actually holds his breath, okay? And he goes, okay, you're having a contraction. And then after it lets up, and it only lasts 60 or maybe 60 to 90 seconds, and that's okay. Baby can hold his breath for that long. But if you get a longer contraction, longer than 90 seconds, baby goes, okay, that's enough. And he may have deceleration. So being in the room with her, knowing what you're looking at and what it should be, that will be a good thing. And then if she has close hyperstimulus contractions, then you want to report that. Okay, so let's look at here. So this, remember we talked about the contractions, and this is their job, all right? So here you have your internal os, and here you have external os. Those contractions will make this internal os start to go up, see here? And makes that external os, makes it to open up. Because here is the cavity of your cervix, see? And that has to come wide open. This all has to come open. So what happens is internal os will come way up, let the baby's head descend, and the external os will fan out. It has to go to 10 centimeters for the baby to be delivered. So this is a good portion here where you see the internal os has now been pulled up, and the external os now is pulled up and is wide open. So that's what that looks like. And that's the contractions that do that. Now, this is the dilation chart that we teach all new nurses how to get in there with two little fingers and to check the cervix. And we do check the cervix when we make sure that we get all the way up. See here, if you just check the external os, you won't get an accurate dilation. Okay, you have to put your fingers, it has to come up to the internal os. Okay, all right, so here you start with one centimeter, and then each time it gets a little bigger. That's 2, this is 3, and you get to know, when you work in that field, you get to know how many centimeters is your fingers. Like 2 of my fingers are 3 centimeters. And so then you learn to check. So what happens, a new nurse, what she does is that she puts her fingers in up in the patient's, and now she says, okay, I got my 2 fingers there. So she comes out and she goes to the chart, and then she measures according to the chart. That's how you learn, okay? You have to do it over and over again. Now here's the contraction cycle. Again, just reiterating here, we have the increment going up, increase, see, up here, the peak, and coming down the decrement. She's slow breathing here in the decrement. Come up, do your hee blowing a little faster, because that's where it's real strong, and then come down the contraction, decrease, and as soon as you can, get her to slow down her breathing, slow chest. She comes down, you have this relaxation period in between contractions, and that's why you want them. You don't want them on top of each other, and then it starts all over again. And here, so when you're doing frequency, again, you're counting from the beginning of this contraction to the beginning of this contraction. That's frequency. And duration would be the time in here, right? How long is this one contraction lasting? Okay, and that's usually in seconds. Okay, so this should be no greater than 90 seconds. All right, and you can chart it also as an intensity, mild, moderate, or strong. All right, so that's your contraction pattern, and that we need those contractions to be in labor. All right, now what's my nursing tip? I have to provide emotional support to the laboring woman, because when you have a lady in labor, she could be very anxious and she could be fearful. Okay, and, like I said, not everybody goes to the prenatal classes, so they come into you and they're looking to you, the nurse, to help. You have to give them support. Now that's a really good test question too, giving support to the patient. And you want to relieve their excessive anxiety, because I'm going to be very honest with you. As an L&D nurse, when I have a patient that is highly anxious and she's real fearful, her cervix does not open up. It's like opening a brick wall, and that's really hard to do, honestly. So I get her to relax. I go over the breathing techniques. I got her on her side, and if she has back pain, we go ahead and maybe do a nice rub on the back, a sacral counter pressure, especially in the early part of labor, due to maybe the position of the fetus head. Oh, yes.
You said that when they're anxious, their cervix won't open?
Yeah. They're anxious and what?
You said when they're anxious, their cervix won't open?
Yeah, it's like opening a brick wall. And so
that was the question in the back of the book, at the end of the chapter.
Yeah, just, just from being a labor nurse, as I have been for many years, when I had somebody who was, scared, and she wouldn't breathe, she wouldn't relax. This is what she did. She was like this. Look, Megan, she was like this. Okay. And she was like, her whole body was all tense. You can't open up. Those contractions, got to work with them. I always tell my patients, work with the contraction. Because when you have somebody working with the contractions open up nicely, and they don't hurt as bad as if you're like this, fighting against it. So a woman has to learn how to work with her body when you're in labor. That's the key thing. work with your body. And so that's why they go to the prenatal classes is so good. I used to teach those classes, and then they would work with their bodies and get to know them, you know, and work and breathe. And boy, they were good. Okay. So let me share my screen again. All righty. So let me share this one here. All righty. So I just wanted to share that with you because it does make a difference. All righty. And those are always good test questions, by the way. Now the passage, well, that's the passageway. We talked about the bony pelvises before, and we all kind of know that the gynecoid pelvis is the most favorable for vaginal delivery. It's just the shape of it, you know. You got a baby's head. Now, thank goodness that baby head can mold down in her pelvis so it can get through there. But it, you know, if you have a planetoid pelvis, that's really a flat pelvis. That doesn't make ample room for a baby's head. It's kind of hard to get through. So what I just want to point out to you, there's two bony pelvises, but the true pelvis is the one that's directly involved in the childbirth. All righty. Now here's just a drawing of the baby's skull. And what I want you to know, you don't have to know all these different bones, of course, but I want you to just to note that you have these fontanelles. These are like the little soft spots on the baby's head. And here you have the frontal, and here you have the occipital bone. And when I talk about the occipital, I'm talking about this part of the baby's head, the back, okay? And so when I talk about like presentation occipital posterior, that means that this part of the baby's head is presenting toward mom's back. I just wanted to show you that just to show you that. Okay, and here is a different lie. So the passenger is in a fetal lie, and what it all means is how the baby position in relation to mom's spine, okay? So her spine goes what, from here, you know, all the way down, right? And so the baby is more longitudinal. That's good. This is called a cephalic presentation. The head is coming first, okay? Which is what we want. And we want a position occipital anterior, perfect for vaginal delivery. Perfect, okay? This is perfect. Now this one here decided that he wanted to lie sideways in mom, okay? So you can see how her uterus is quite different and baby's lying sideways. This would definitely be a C-section, all right? Remember, breech presentations would be a C-section, transverse lines would be a C-section. So here's our different, how our passenger looks. Our passenger is our fetus. And so you don't want the shoulder presentation because that would be a C-section because his shoulder is presenting down the pelvis. Mr. Frank Breech here, he's got his feet up to the head, all right? So he is just, you know, saying, here I am, folks. This would be a C-section. And this is just a regular breech where you can see his legs are more, they're not up like Mr. Frank Breech. They're just kind of crossed over. And then you have your single footling breech here, where you actually do have a foot that comes down, and that's what's presenting. And that would be C-section. So all these here are C-section babies. All right, now let's talk about the psychic, okay? We talked about that before, and I really do believe in this. The mental state influences the course of labor. I have seen it over and over again. And the woman's culture and individual values do influence how she'll cope with childbirth. And my biggest story I do tell is about culture, is my American Indian woman. She asked me very nicely, she said, would you mind if my tribe came into the labor room? It was a big labor room, thank goodness. And I said, okay. And she says, it really would mean a lot to me. And I said, okay. And so they came in and they surrounded her bed and they did, you know, their rituals, which was beautiful. And her face just glowed, you know. And I tell you, she had a wonderful labor. She handled every contraction with such strength, and everything worked out good. Now, just think, if I wasn't sensitive to her culture, and I would say, no, oh, we can't do that. That's too many people. Then that would have had an influence, a negative influence on her labor. That's where I'm coming from. And I've seen that so many times, how women do cope with childbirth. Okay, so I know you've seen this in your textbook, and I just wanted to show you here what it all means. So here's the mom's pelvis. So here's her interior, and here's posterior. Okay, now all this means here, this baby is in a ROP position. This is how he's laying. So he's laying to mom's right side. That's his back. And his back of his head is to mom's posterior. So his back of his head is to right back here. This causes, write this down, OP position causes a lot of back labor, intense back labor, because you can see why. Okay, and so, we want to try to help flip that baby around if we can, to help her with the back labor. So with back labor, you give her good sacral counter pressure, and that really does help. Now, this one here is laying to mom's left side. So it's on his back is to a mom's left side, and the occipital is occipital posterior. The back of his head is to mom's back. Again, right occipital anterior. Okay, that means the back of his head is facing mom's interior. Okay, a lot more room. See how the head, it looks different from this one. This chin is like sticking up, and that's hard to descend like that, and causes mom more pain. This here, his chin is tucked down. He's tucked down, and he's ready for his little entry. Okay, so that's what this means. So this is why when I talk about OA position, this is why I'm talking about. Again, the occipital part of his head, the back of his head, is to mom's interior. All right. Now, some signs of impending labor. That means labor's coming. All right. So we have some Braxton Hicks contractions. Remember those irregular contractions I talked about earlier? Okay. That means that body is gearing up. We're getting ribbed up. Yeah. We're getting ready for true labor. Okay. Maybe she has increased vaginal discharge. All right. The bloody show. That's that mucousy. It may look with a tinge of red because it may have a little bit of blood. It may look brown, but the body gets rid of that. That has been laying up there in the cervix, protecting the uterus from any kind of bacteria going up. That's the mucous membrane. That's the mucus plug. It really does help. And now she's going to get rid of it. Okay, so may have some bloody show. How about rupture of the membranes? Okay, her bag of water breaks. All right, it might be a big gush, or it might be just a continuous trickle of fluid. All right, that means labor is coming. All right, she might get an energy spurt, and so she really wants to get things done. I've seen women want to make sure the shopping is done, make all the laundry is done. Okay, now this is in your book. This is the mechanisms of labor. This is just how our babies descend. All right, and so we're going to go over station in just a minute. I got my little drawings for you and make it easier. Engagement is now his head is down. All right, hopefully it's an OA position. It is in the pelvis, the true pelvis. Then his body is in flexion, and then he does inside, he does like this internal rotation because he has to come through, and then he comes down, and you got extension, and then he comes out, and he does another external rotation, and then the rest of the baby comes out. So here, now, a good test question could be, about the station, like -2, -3, -4, -5. Those are all above the 0 station, the ischial spines. Okay, they're above. Okay, and then anything below the ischial spine, which was 0 station, would be +1, +2, +3, and to +5 were delivered. So again, up here, these are ischial spines, okay? Now, these are very prominent. When you do a badge exam, you can actually feel the ischial spines, okay? And so here, the head is at a 0 station. You can see that, okay? All right, so again, good test question. Could be, above, what's above? And that would be the -1, -2, -3, -4. Now, -5, he's way above, and his head is way above, and he's about floating, okay? And then, of course, anything below is getting close to delivery. And that's how we determine where the head is, because when the head is at a 0 station, that head is actually putting good pressure on the cervix and makes mom dilate a little bit easier, makes those contractions really effective. All right. Again, this is how our babies come out. And you can see here, remember the amnion, the chorion, the layers of the uterus, okay? And here you have your uterine wall, and here's the cervical canal. All this is going to get very thinned out, as you can see, and how the head now is starting to engage, all right? And here you have him being, again, coming down, and the head is molding here to go ahead. It kind of gets what we kind of looks a little like this getting elongated, and you can see that here. Okay, now take note to the symphysis pubis here. This bone sometimes is really hard for moms to push, especially in that OP position I talked about, right through here, because the baby's chin is up and not down like this baby, okay? And then you have your umbilical cord, and that cord can get in the way too, so you gotta be very careful and make sure you're monitoring as he's being born. And you can see here now, he's expelled, and then here the placenta is breaking away from the endometrium, okay? All right, and here now, the placenta is out, guys, okay? And this would be, I'm looking at this kind of drawing here, this placenta. This would be the neonate side, which is called the Schultz, all right? And the other side is the maternal side, and that's called the Duncan. All right, and then here, now take note, during the recovery time, you want this uterus to be contracting, okay? Because when the placenta comes out, it's like an open cut up inside the uterus, up in here. It's an open cut, and she can bleed a lot. And so you want this pressure on that area to make sure that she doesn't bleed. I don't want my patient to hemorrhage, all right? It's called postpartum hemorrhage, and I don't want that. So I want this top of the uterus, which is called a fundus, I want that fundus to be firm. If it's not firm, what are we gonna do? We're gonna massage the fundus. Give it a good massage, and you'll get it. You can feel it come up in your arm, your hand as you're massaging. You can just feel that uterus start to get real firm, and then you can see that she'll have a decrease in bleeding. All right, so now you're thinking, when do we go to the hospital? All right, so, or wherever she's going to deliver, or the birth center. Well, when she has contractions, okay, and it could be in the early or late phase of the first stage of labor. So it could be from 5 to 7 minutes apart, but they're rhythmic, and it lasted maybe 60 to 70 seconds in duration. Okay. And she's like, oh man, these really grab. Okay. And so it's time probably to go. Okay. Now, ruptured membranes, if the bag of water breaks, she has to go to the hospital because you only have 24 hours to deliver the baby. Otherwise, you start to get into an area of infection. Past 24 hours, they can get an infection. If mom gets an infection, who else gets an infection? The baby. Okay.
The feeding.
Now bleeding, if she has a lot of bright red bleeding or dark red bleeding and it's not bloody show, we need to get her to the hospital. Now, she reports to you that she had a decrease in fetal movement. You want to get her to the hospital, okay? And I put it this way: any other concerns, go to the hospital, okay? We'll evaluate you in triage, and we'll make sure everything is okay. Now, when she comes to you in the hospital, okay, you're on triage, we're going to do 3 major assessments. Okay, we're always going to put the fetal monitor on. There's 2 parts to the external monitoring. You have one that goes on the baby's back to pick up his heartbeat. That's the transducer. And then you have the other one, the tocodynamometer, which you put the toco on the fundus, the top portion of the uterus, because that's where you're going to pick up the true contraction. And so I got that. I'm going to assess the fetal heart rate, and it should be between 110 to 160. All right, 110 to 160 is my normal. Now, I'm going to have a blood pressure cuff on mom. I'm going to have a pulse oximeter, because now I'm going to get her temperature, because now I'm assessing mom's condition. Okay, so you can see in maternity, we have 2 patients. All right. And then I'm going to do probably a sterile vag exam, as long as she doesn't have any bright red bleeding. And so I'm going to go ahead and do a sterile vag exam, because I want to see what she dilated to. She's been contracting, she said, for 8 hours at home. I want to know where we're up to now. Okay, so we're going to do we have a sterile glove, and we're going to make sure when we go in, we don't touch anything, and go straight into the vagina to get up to the cervix. All right, and then now you can determine, Nurse Megan with me today, she determined this patient is in true labor. Okay, so we're going to admit her. And so we're going to get permits and consents. And I tell you, if she's in early labor, or the latent phase, which would be nice, this will be easier to get. As she gets in the more active phase, she's going to be dilated more. The contraction is going to be harder. That these consents and permits get a little bit harder to get, but we get them. And then we're going to, when we draw her IV, we're going to draw her blood. Okay, when we put an IV in, we're going to draw her blood, and then make sure she's all nice and clean. We don't do any shave anymore, and determine the fetal position and presentation. We can determine that. One, there's a couple ways. One, you can do a Lieber-Pols maneuver, and we can determine that. Okay, Lieber-Pols maneuver. Or I can put my fingers for a sterile vag exam, and when I go there, I want to make sure I feel something really hard, because that would be the baby's head. Okay, and I want to feel that to make sure baby is cephalic and not in breech. If it was a breech baby, that when we go in, it would be softer. All right, so now we, as triage nurses, we have to determine this lady's in false labor or true labor. Okay, so now another patient comes in, and so she says, I'm having contractions, and they're like 5, 7, 10 minutes apart. So those are what we call irregular contractions, and we send her out walking. Okay, well, first we do our assessment on the fetus and the mom. Okay, everything is normal. Okay, good. So we'll send her out walking, because we know walking stimulates contractions. But if you're not in labor, that walking actually relieves the contractions. So that's the big difference between the false labor and the true labor. Okay, and then bloody show. She usually doesn't have any bloody show, because she's not having the effective contractions to open up the cervix. And so she doesn't have any bleeding coming from the cervix. Because I tell you what, the cervix is a very vascular area. And when it starts to dilate, it will slough off some blood, and that will be the bloody show with the mucus in the blood. Okay, but false labor, we don't have it, because there's nothing happening to that cervix. And then another determinant is there's no change in dilation or effacement of the cervix. So unfortunately, we have to tell Mrs. Jones that it's not time yet. Okay. And we have to send her home. And so we make sure everything's normal and she knows when to come back. All right. Now, my other patient, maybe Mrs. Nugent comes in and she says, I have contractions are every 4 to 5 minutes apart. Okay. And they're lasting from 60 to 80 seconds in duration. All right. So we're going to do our assessment again, blood pressure and everything on mom and on baby, make sure that the fetal heart rate is within norm. And so then we'll send her out walking. All right. And while she's walking, those contractions become stronger and more effective while walking. All right. That's a good thing. I love when they come back and they tell me that, or I see them in the hallway. Sometimes what I do is I go out and I go walk the hallway where they are, and I can see them in the hallway and they're bent over or they put their back toward the wall, and the contractions are getting better. Okay, well, that's what we want. We want to help our patients to get into good labor. And sure enough, she says, oh, my back is killing me. Okay, we're doing good. This is all good things. And then she's got some bloody show. Okay, she says, yeah, I got something I feel something coming out. A lot of times I'll give them a pad because in case she does get any bloody show, that she doesn't ruin their nightgown thing. And then guess what? We're going to recheck her. All right. And sure enough, she's dilated and effaced the cervix. Her cervix changed. Maybe she was 2 centimeters when she came in, and I sent her out walking, and sure enough, she changed to 4 centimeters. Am I in labor? Yes, you are. You're doing good. You're progressing. And so that lady gets admitted to the hospital because she's in true labor. Now, I'm going to tell you, this is a good test question. So you probably want to really take note to between the difference between false labor and true labor. All right. So how about we do this? A laboring woman is uncomfortable. All right. And her labor has slowed down, which happens. Okay. So which instruction should the nurse give to the client to help stimulate her labor? How are we going to stimulate her labor without giving any drugs?
Encourage the woman to ambulate.
You got it. You got it. You're right on target. Good. Okay. So what's going to be now Nurse Megan's nursing care? So now this is before birth. So we're going to get her admitted. We're going to do the nursing care. We're going to monitor the fetus, right? Make sure that the fetal heart rate is between 110 to 160. And we're going to monitor the laboring woman. Okay. We get her vital signs. And our biggest job too in that room is helping her to cope with labor pains. Okay. Giving her support, telling her when to breathe. Okay. Encourage her to breathe. A lot of times they forget. Even if they do go to prenatal classes, you know, when they get hit with a contraction and is an effective contraction, they forget and they don't breathe. So our job in that labor room is to help them breathe. Okay. And they do appreciate everything we do. So here again, this is just a picture of a monitor, and it's our standard of care to monitor everyone that's in the labor room. So this here is the numeral reading of the fetal heart rate. So here, his baseline is a little low, it's 113, but that's okay because again, it falls into the norm rate, okay? Now here, her resting tone is at 22. So that means 20 is a good resting tone. Remember that resting I showed you between the contractions? So that's good. Her uterus is going down, which is good. Now, her blood pressure, 135/70. That's okay because again, remember the systolic will respond to pain, where the diastolic, which is actually what the heart puts out, is okay. All right, we're doing good. And then we got here, her heart rate is up a little bit, but whenever you're experiencing pain, your heart rate will go up a little bit. And so this is a good printout. And while we have this, I can show you the accelerations are A-okay. Look at those beautiful accelerations. And she's having an acceleration at the same time she's actually having a contraction. Look at that. Isn't that beautiful? And here again also. And this side here is your contraction. All right. So here's a nice contraction and she did well. And when we're looking at duration, remember we talked about that? See this solid line here and this other solid line here? That's 1 minute. All right. These are all seconds. Okay. So when we count duration, we're counting the seconds. So here, going back to this contraction, we would count like here 10, 20, 30, 40, 50, 60, 70. Oh, let me go back to my other side. 70 seconds. See? So that's why we don't want it too long, because baby has to, remember, respond, has to hold its breath during a contraction. All right. Because what happens, the contraction will actually put pressure on the baby's cord and will compress it a little bit. So we don't want it too long. We want to make sure our baby gets enough oxygenation during the labor. Okay. So that's a good example of a strip here. And you can see here, there's a number on every panel, you know, and so we make sure that it stays all together, because we got these funny lawyers out there that look for things like that. They go, oh, there's a panel missing. What happened during that time? Okay. So anyway, this is the monitor strip. Okay. And this is another kind of monitor too. This one doesn't have, the Toco diameter is not really on that fundus of the uterus very well, okay? But because you can't really see contraction there, okay? All right, and this little baby didn't have any accelerations. I like the other one better because it had accelerations, though this one has beat to beat variability. It didn't have any accelerations. All right. Now, again, going over to the monitor, that's the baby's heartbeat. That's where the contractions started to go up. Remember, resting tone's about 20 millimeters. And so this is at 26. And then her blood pressure and her heart rate would be here. This is actually a twin monitor, as you can see, because you can have one here. This is the Toco, and then here's your other twin. All right, so anytime that the fetal heart rate goes outside the normal limits, you know, either bradycardia, which would be below 110, or tachycardia, which would be above 160, you always want to make sure that it's reported, okay? And if you're an LPN in the room, you make sure that you report that to the RN, and then the RN will look at, interpret that strip, and then she'll call the healthcare provider. Now, this is a good little slide on the different types of fetal heart rate patterns. Okay, so again, we got the baseline, 110 to 160. Anything below 110 is fetal bradycardia, okay, as you can see. Anything greater than 160 is fetal tachycardia. And then we talk about variability. And so, you know, those squiggly lines I showed you, all right, that's what we call beat to beat variability. Just like, let me say, just like on a normal person's EKG, okay, you wouldn't want any kind of absent beat to beat, okay? Absent would be on an adult EKG would be what? Be like flat, okay? That's not good. So absent's never good, okay? Now, marked variability, that means the beats are like greater than 25 beats per minute, which was kind of a lot. You know, it's like up and down, up and down, up and down. That's not good either, because that's not good for the baby. His little heart rate is just, his heart's just going boom, 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 all right? And so we don't want that either. You see that a lot when moms take in cocaine or drugs before they come into the labor room. Now, moderate variability is what I want. It's like 5 to 25 beats per minute. And there's that beat to beat that I showed you, and it's just up and down. It's like those beautiful little squiggly lines. That's the variability. When you have that, just write down variability equals fetal well-being. Okay, so if I have a fetal heart rate of 140 and I have moderate variability, my baby is in good shape. My baby is tolerating everything wonderful, and that's what I want. Okay, so let's go back here. We're gonna talk about earlies. Let me show you. Let me go up here and let me go to my whiteboard. And I'm gonna show you now. Let me go to my whiteboard. Where is that whiteboard? Here we go. And let's go here. All right. And I got my, yeah, okay. So I'm gonna show you contraction. There we go. Contraction. Okay. Now, if I have fetal heart rate and it's usually about 120, doing good, I got those squiggly lines, okay? Now she has a contraction, the baby's heart rate kind of goes down with the contraction. See that? Comes back up though, and it comes back squiggly lines, okay? This is called an early. So early deceleration, okay? And what's happening here is we're having head compression. So the baby's head is descending. So what happens is when his little head gets squished, he gets like a vagal response and his heart rate goes down. That's an early deceleration. Early deceleration are caused by head compression. And then he has the squiggly lines and he's doing good, okay? And again, he might get through that one just fine. Now this one, if his heart rate goes down after a contraction, this is called a late. And I sent out those little cartoons to show you, but this is a late. A late is occurring after the contraction. That is not, this is a late is non-reassuring. Write that down because you'll see that again. A late deceleration is a non-reassuring pattern. All right, we don't like it. So remember, I think maybe you remember you learned this. It's called veal chop. Let me write this out. This is a way to remember these different fetal heart rate patterns. Okay. All right, and then we put C here, and then H, and then O, and then a P. Oh, excuse me, a P. P, here, come on, P. All right, there we go. All right, the V, write this down. So write down veal and then chop. Okay, so V stands for variable decelerations. Variable decelerations. Okay, and what happens with a variable? Let me go over here and show you. Let me erase this one here. Okay, let me go back to my pen. All right, and with a variable, you have, it varies. Okay, so it doesn't occur with it doesn't have to occur with a contraction. What happens is you got cord compression. That's your C, cord compression. And what happens? You have a sudden drop in the fetal heart rate, okay, but a sudden recovery back up. And that kind of looks like a V. Variables can be in the shape of a V, they can be in shape of a W, and they can be in the shape of a U, okay? And so they vary in size, they vary in when they occur. It's just caused by the cord, C for cord compression. All right, everybody got that? You got that, Megan? And then we have an early. Remember I described that early to you, and where here he has his heart rate goes down with the contraction. Now this lower portion of the deceleration rate in here, that's called a nair, and that's N-A-I-R, a nair. All right, that the nair is the lowest part of the deceleration. So that kind of goes along right with the acme of the contraction. See there? And that's head compression. So write down E and write down early. Early deceleration is caused by head compression. Over here on the H, write head compression. Okay. Now the A stands for accelerations. And remember on that strip I showed you, and I said these are great accelerations, and these were A-OK? That's what it is. The O is A-OK.
What's the A stand?
Accelerations. So that's good. It's like your heart rate. When you get excited, you know, your heart rate will go up, your heart rate will accelerate, okay? And same thing with a baby. His heart rate will accelerate and we're in good shape, okay? All right, and that's A-OK. So the O in CHOP is A-OK. Now, here's our L. L is for late deceleration. Late deceleration. All right. That's the one that after the contraction, let me just make another contraction here. Okay, and here he is. Here he's going along, and mom had this contraction, and all of a sudden he went, after the contraction, his heart rate went down. All right. That's a late deceleration. Well, a late deceleration is caused by uterine placenta insufficiency. Uterine, U-T-E-R-I-N-E, uterine placenta, P-L-A-C-E-N-T-A, insufficiency. What it means is that the blood flow, there is a diminished blood flow between the uterus and the placenta. And it's never good to be late. So late decelerations are non-reassuring pattern. You need to let the physician know. So, and you need to put mom like on her left side and follow that. Remember, let me see here. Let me write this down for you. Follow that mnemonic lion. Remember lion? Okay, let's hear L, I, O, and N. Let me get rid of this. Okay. So what you do when you have a baby that has like a late deceleration, or you have a baby that is maybe doesn't have has absent variability, remember the mnemonic lion. So the L stands for lateral position. Put that patient on her side. Make sure, and the left side is the most preferable. So put her on the left side. Okay, so we got her on the left side. And I is for IV. Make sure she's got IV and give her a little more fluids, hydrate her. Okay. O is for oxygen. Oxygen. Deliver oxygen 8 to 10 liters via a very tight face mask on her. That's the O. All right. And then N, you need help in that room. So you're going to notify the physician. So this is a good mnemonic to remember is lion. When you have a baby who is not doing good, having a late deceleration, and you need to help this baby. Otherwise, if you don't help him and he continues to have late decelerations, he can die on you. And what happens is that they have these recurrent lates, and then you lose your variability, and then you lose your baby. Okay, so I'm going to erase this. Have any questions with this? Okay, so I'm going to go ahead and we'll go back to our recording here.